I'll just give a little bit of a background. I think there are some people in this room that know me. I've sort of become one of the M3 family, so I've spoken a few times. So just to give it a little bit of a context before I start the rest of the talk. So I actually grew up in Malawi. I'm the oldest of 9 children. My sister Mabel is actually here. What number are you, Mabel? 4, yeah. As I get older, that's starting to get real fuzzy. So we grew up in Malawi in a very small village outside of Salima, and we pretty much grew up, in a very small village. When we went and fetched water, from the rivers when we were younger, we walked, everywhere. The best transport that we would get in Tonje was an ox cart. On a really good day, sometimes we would have a bicycle to get around. Most of my elementary school I actually attended under the tree, and so it was a really humbling, beginning to my life, and I'm really grateful to God because, in the middle of a, small village in the middle of nowhere, God sort of found his way and found us, as a family. So in 1994, miraculously, I actually got a scholarship from a United States physician, Donna Ivy, who actually brought me to the United States because she thought I had a lot of potential, but wasn't really going to get much of an opportunity to become a doctor. So I've now been in the United States, and I'm a trained gynecologic oncologist. I work for Houston Methodist Hospital. And part of my journey after I came here was really to start seeking what my purpose was and why God had chosen me, because there were other kids in Tonje that were very brilliant and should have had the same equal opportunity as I did. And some of my trips back home really sort of, brought that full circle where I kind of had to ask myself what was the why and what was my purpose. And so part of what I'll be discussing is sort of what has happened since then. So we founded Pothawira, which is safe haven in English. It's sort of a comprehensive village. We have an outpatient clinic there. We have a maternity ward. We also have an orphanage that has 120 kids that live there. We have a school that has 400 kids, starting from kindergarten to 8th grade. These are kids that wouldn't have access to education. I really truly believe that the future of Africa, lies in the minds of the children, because there are many Annies there that just need to be given a lift. They need an opportunity for an education. They're innovative. They can solve all the problems that Africa has. They just need the chance to get a seat at the table and be able to do that. So that's just the background. So now I'm going to talk about the topic at hand. Maybe easier for me probably if I look over this way. So today we're going to be talking about some of the devastating realities that still remain around maternal mortality, and I'll mostly be focusing on Malawi. And most of the issues going on in Malawi with maternal mortality are essentially affecting most of sub-Saharan Africa. So the population of Malawi, I'm sort of doing a comparison, because now I'm like part Malawian and kind of part Texan, like a child without a country at this point. When I'm in Texas, people think I'm strange. When I go to Malawi, they think I'm kind of strange too. So I am navigating between the two countries. Texas is the country. So population of Malawi is about 18 million, and this is just so, I have this side-by-side view just so we can kind of see the differences. Life expectancy in Malawi is 62 years, in Texas about 76. The median age in Malawi is about 16.8, so that's like 17. So it tells you how long people are actually living in Malawi, because 70% of the population is under 30, and 52% under 18, which is very different from here. The median age is about 35, so we're about half of that. The maternal mortality rate in Malawi is about 634 per 100,000 compared to 34 per 100,000. I went through an OBGYN residency here in the United States for 4 years, and including the times that I did, my rotations through obstetrics, and I never saw not one maternal death in my entire, training. And yet in Malawi, I could be there for 2 weeks, and I see it happen in a 2-week period. Under 5 mortality, 112 per 1,000, compared to Texas, about 35 per 1,000. 74% of Malawi lives below the international poverty line. They make about $1.25 a day, income about $620 to $634 per year. There are people that make that in an hour. 17% in Texas live below the U.S. poverty line. 23,000 for about a family of 4. So an estimate of 303,000 women die in pregnancy and childbirth in the postpartum period, and 99% of those are happening in low-income, middle-income countries, especially sub-Saharan Africa and Asia. So elimination of preventable causes is one of the most important targets that we have to look in combating maternal and mortality and morbidity. So the causes of maternal deaths in Malawi, Africa, and really most of sub-Saharan Africa haven't changed significantly. One of the number one causes is hemorrhage, postpartum hemorrhage, infections, and hypertensive disorders such as preeclampsia and eclampsia. So women are about 51% of the population in Malawi, and 45% in the reproductive ages between 19 to 49. 29% of the pregnancies and deliveries are actually happening in adolescence, so between 15 to 19. So a lot of the women that are dying in childbirth are very, very young women. The notable shift in the factors that are contributing to maternal deaths has been seen to change from the 1990s to what we're seeing now. Prior to that, most of the issues that were involved was really delays in seeking care. Most women were actually delivering in the villages. Most of them were seeking care from, one of the women in the villages who was sort of the designed person to do all the deliveries. And so the deaths were happening, in the homes where most women were not seeking care in a facility setting. What is now interesting is that the higher number of patients are now going to facilities for deliveries, but there are more women now dying in a facility when prior the focus was let's get the women to the hospitals, and the public health system has actually done a fantastic job of getting the women from delivering from the villages to now seeking care in facilities, and now they're crowded up in the facilities and then dying, giving birth in the hospital. So that's been really the big shift, and so now the changes are more focusing on what is happening in the healthcare facilities that is actually, not making as much of a difference as we thought it would in terms of decreasing the maternal mortality rates. So a lot of people have kind of looked into different studies. Some of this was actually in the British Medical Journal, and sort of looking at what are the 3 delays that we're seeing. And so like I said before, in the 1990s, it was more the delays that were involved in seeking care, where for one reason or another, the patients would make a decision to deliver, in the village versus going to seek care. The type 2 delays are the ones where it's an issue where they have made a decision that they want to get to a healthcare facility, but there are many factors that are preventing them from being able to reach the facility, either, transportation-related issues, family dynamics, economics, but the desire to deliver the facilities there. And then the type 3 delays, which are the ones we're seeing the most now, is where the patient is in the facility, but there are delays in receiving care or inability to actually make the correct diagnosis and treat the patients that happen in the facility that are resulting in continued increases in the maternal mortality and morbidity. So on the type 1 delays, as we discussed before, the economic issues, when somebody's making $1.25 a day, often we've seen that to make a decision even to leave whatever work that they do to go to a hospital, they usually have to be really, really sick. They're not going to take a day off for just feeling a little bad. So most patients usually will wait, or families sometimes, will wait until their children are really, really sick before they, lose a day's work and travel to be seen at a hospital. The distance to get to a healthcare facility is also one of the limiting factors when they have to calculate what it would take for them to go from the village. They have to find a bicycle taxi, get an ox cart. Most people don't own these things, so usually you have to find somebody that owns a bicycle, find somebody that has an ox cart, and you have to pay, to be able to get there. And so often that's also impeding their ability to be able to seek care. Some of the women's knowledge of the danger signs of labor and are a little bit skewed. There are some traditional beliefs about what's normal and what's not, and so depending on who's advising the young mother as to when they should actually seek care, sometimes that can be an issue. Autonomy for a lot of women is still coming up. And I think women's situation in Malawi is getting better, but for the most part, most women are not working. They depend on their husbands for income. Most of them really, especially in the villages, don't live independently, in a sense that the decisions that they need to make, even about their own health care, are usually dictated by the person that financially provides for them. So often, sometimes there's delays in that associated with the fact that they just don't have the freedom to just pick up and decide that they're going to go to the hospital without going through what will be considered culturally proper channels to leave the home. Some of it also comes from negative experiences when they've actually gone, to visits in the hospitals where, maybe when they arrived, they were treated poorly. The hospitals are overcrowded, they're under-resourced, the workers are exhausted. And so sometimes, depending on the previous experience that they've had, they're no longer interested in being able to go back and seek care in a medical facility. So I was just going to share this story. So Naomi is one of the babies that we have actually at our facility. So she, her mother, was, her situation was associated with one of the type 1 delays. So her mom was pregnant with twins. Her husband was not living with her because she was, out. He lived in the city where he was working, and she was living alone, taking care of the children in the village. So she stayed at home as long as she possibly could because there wasn't going to be anybody else that would take care of the other kids at home. She ended up going into labor, and at some point decided that she will go ahead and walk to the district hospital for the delivery. So she was actually on her way to the hospital, was laboring along the way, and this is, some of the things that happen with the women. And at some point, it was clear that she was going to deliver on the road. So her friends just basically took her into a cornfield that was close by, and she basically laid, on the dirt there. And she delivered Naomi, who was the first twin. And then before the second twin delivered, she started having significant hemorrhage. Her friends didn't really have a means to help her, so she ended up essentially bleeding and dying in the cornfield after Naomi was delivered. So they just, tore off a piece of her chitenje, tied up Naomi's umbilical cord, and literally brought her to the orphanage. I think I remember my mom describing that when they brought her, she was still covered in dirt, and from her umbilical cord stump, there was just dirt and drips of blood coming, and her mother was 27 years old. Because unlike what we have here in the United States, they couldn't have just called 911 and get an ambulance to pick her up from the road or to pick her up from the village and take her to the healthcare facility. And this happens very often. You go to a lot of the hospitals, you find that women now are becoming aware of the fact that this is an issue, and they will actually camp out under a tree when they know that they're in their last trimester. Most of them don't even know when their last menstrual period was, so they just will estimate, I think I may be close. and they will just go to the hospital and they will literally sleep outside the hospital. They will cook, family members will bring them food, and they lay outside probably for the last month of their pregnancy to avoid situations like this, which happen very often. But if you have young kids and you have no one else to take care of them, you don't really have the luxury to go lay under a tree for a month and leave them without care. So the other type 2 delays that we talked about are issues involving, being able to actually reach a facility on time. A lot of times the distances between where these remote villages are and being able to get a healthcare facility are, significant. Most of the women, it's a real burden to be able to find transportation. And like I talked about, you either get an ox cart, a bicycle taxi, but even that, will cost money. Some of the places you can't even get a car to get to. Some of the other issues is there's small health centers that are all around the country. They may have an ability to just do basic primary care, where they're just giving antibiotics, treating infections, treating malaria. And so women will show up there in labor and they don't have the capacity to actually do deliveries. And so those women have to be transported. Most of those facilities either have no ambulance, or sometimes when they have one, most of the times there's no fuel. And so usually it's left up to the patient to be like, well, you're in trouble, but figure out how you're gonna get to the district hospital. Some of the places, it's also a delay in making decisions. They may see a patient, they're unsure whether the patient is actually in trouble or not, and most of that also has to do with the amount of training that the staff has had. How much do they actually know and recognize as a danger sign that says we need to transfer the patient over? So that can also, keep patients from being able to be taken to the hospital. So this is, so I was just sort of giving examples of some of the more common transportation modalities that the patients are using. As you can see, there's a bicycle taxi there, and then ox cart. That's going to be mostly what people are going to be using to get out of the village. That's not going to get you there very fast if you're having a hypertensive crisis and pregnant. So I will share some of this story, but I just wanted to use it as part of the examples of some of the type 2 delays that we were talking about. So Nelia is a young woman, about 26 years of age. So she actually delivered her first baby by C-section, who died. She had a cord prolapse. She showed up at a health center and her water had broken, and cord prolapse is when the cord comes out for the non-medical people that may be in here, and so that means the baby would strangle their own umbilical cord. And so when that happens, literally like when we're here in the US, you push the baby's head up off the umbilical cord, and like you want to get to the OR in about 5 minutes and get that baby out. But when you're in Malawi and at a tiny health center where they don't have a capacity for a C-section, they don't have ultrasound, most of the times they literally like have the women, almost like standing on their heads to keep the baby's head down, and then somehow find a way to transport them. And some of the ways that these women show up, the position that they've been in for 45 minutes, 1 hour, an hour and a half to get to the facility is amazing. So by the time she got there, the baby was actually dead. And on this picture, she had actually come to the healthcare facility this time for delivery. And unfortunately, because the hospital only has 2 operating rooms, they have a catchment of about 500,000 people. They have 1 minor operating room and 1 major operating room. And she labored for 18 hours waiting to be able to get into the operating room. And then at some point, had a uterine rupture that was devastating, and she lost her second baby and also lost her uterus. So again, these stories are happening often. I have part of her story that I'll share more in the plenary session. So that's her baby there, and this is her miraculously alive after. Type 3 delays, again, these are failures to get proper, care and proper diagnosis, and that is what we're seeing most now. We've finally gotten women into the hospitals, but we're still finding that they're getting there and not getting the care that they need. And so what is happening? One of the issues is the long waiting times for assessment. There are patients that when we're sending them to the district hospital, they will often cry and ask, is there something else that you could do? Because you can send a patient to the hospital and they can sit for 3 or 4 days before assessment. Mabel and I had a very close family members. Their mother actually miraculously made it through delivering twins vaginally at a nun facility. The girls actually got old enough to about 17 years of age. And one of the twins started her period, but the other one actually never started her period. And at some point, it was apparent that she had an imperforate hymen because she was having cyclical pain, but she was not having the bleeding. It's a very simple procedure to actually fix that. And so she was referred to the district hospital, and they went there to be evaluated so they can basically just remove the area, and then she'll be able to, start her menses. But it took a week before anybody could actually get to her because the facility was so crowded. And it was one of the toughest things that we experienced as a family, because the 17-year-old girl who had made it through the first 5 years of life as a twin, who was born small under the worst circumstances, literally died at Kamuzu Central Hospital with an imperforate hymen because nobody ever got to her. She got an infection, she got septic, and she died. And part of that just has to do with the sheer volumes, that the hospitals has. The doctor-patient ratio in Malawi right now is about 1 to 50,000. So the majority of the patients that are there aren't actually being assessed by physicians. And so, you make it to a facility like that, and then you find out that you sit there for a week until your 17-year-old dies. What is going to bring you back the next time you have an emergency? So, the lack of availability of essential equipment, like we're talking about. So sometimes you know what to do about something, but the equipment that is available to you doesn't allow you to do it. I had situations where I remember, my dad trying to resuscitate a baby that was dehydrated. He couldn't get an IV, but he had nothing for central lines. He knows how to do an interosseous needle for, be able to rehydrate, but there was none of that available. And so you sit there and you have the knowledge to intervene, but no equipment to do it. And so the only choice is basically sit there and watch a 5-year-old die from dehydration because you don't have anything else that you can do to rehydrate. The skilled personnel and staffing, with poor competency. One of the things that happens there, because the work pool is so needed, the shortage is so high, often people will go through training, and as fast as they can get you into a hospital, they just put you in there. I remember once going to the district hospital of Salima, which is a huge referral center. All the health centers are sending their patients there. There was a young woman, she had literally just finished an internship, and she was the doctor at that hospital for 500,000 people. And there were patients coming, and she would grab us because she didn't know how to even, there was an MVA that had happened. She didn't know even how to start assessing, a patient after a major motor vehicle accident. So, I'm an OB-GYN. I'm like, what are you calling me for? Is there a baby coming out? Yeah, I know how to do that. But it's they're ill-equipped, because she's just had 1 year of rotating around different departments, and then they handed her an entire hospital to run as a chief medical officer, on her own. And so often you will find that there is some lack of competency in being able to even recognize the danger signs, which leads to the poor outcomes. Again, the missed and incorrect diagnoses that you would usually see. So this is a sobering list for me when you're going to a hospital in Malawi. So we do antenatal teaching, and so often they'll tell the women, this is what you need to pack when you come to the hospital. And so this is going to a hospital facility because they are lacking things. And so this is the list that they will give the women to bring. Bring a plastic trash bag, because usually they will come to the hospital, there's no beds, there's no mattresses. So they actually take that black plastic trash bag, you cut it, you lay it on the floor, and that's essentially where they deliver. It allows them to deliver, and whatever is involved with the delivery, the blood, the placenta, then it can just sort of be picked up together afterwards, and you just sort of throw it out together. They bring strings so they could be used to tie the umbilical cord, because there's no guarantee that they're going to have clamps for the umbilical cord. Bring a razor blade, because there may not be anything to actually cut the cord. Chitenje, those are like the sort of cloths that the women usually tie around themselves. There's no baby blankets. There's no blankets even for you. So you bring your own things to cover yourself and to cover the baby. And there are no hospital gowns for the patients either. And then a matchbox. So after you deliver, you basically get your, placenta, the trash bag, and they pick that up, they go outside themselves and basically burn it. And very sobering lists when you look at what, for me now as an American physician, what I see women bring in their hospital bags when they come to the United States. Hospital for delivery. So this is sort of an example of what you would see in a waiting room. Those are patients on their side. That is a Kamuzu Central Hospital, which is even the biggest hospital in the country. And there are patients that are actually sleeping in the waiting room overnight because they've seen all they could see for the day. They leave. Some of those patients will die in that waiting room before they actually make it to, be seen at the facility. This is at the district hospital that is where we're located. That's actually me assessing a patient who's in labor, and as you can see, she's laying on the trash bag. There's a couple of beds, that are available there, some of them with mattresses and some of them with none. And when you're actually walking through the labor ward, they're just like women on the floor. Some of them are bleeding. There's maybe one or two nurses in there. I was actually with Sandra on one of those occasions, and I was walking by, and I realized there was like a baby coming with one of the women that was laying on the ground. I think I had time to maybe get a glove, and just like reach over and help the deliverer. While I was doing that, in the corner was a woman who had delivered. She was holding her baby, and you could see like a stream of blood coming. She was actually having a postpartum hemorrhage while she was sitting in the corner, and she never made a noise. She never complained. She just sat there, but you could see that she was slowly getting weak, and we had to grab her baby, go lay her on the gurney, and basically start the process of evacuating the clots and getting some, medications to try to stop her bleeding. And some of that is just the staff is just overwhelmed and under-resourced, and they can't get to these patients. And the operating rooms are sobering. Now that I've been here and I've worked in the United States, it's a completely different thing when I go back home and I see what I see. And it's a constant struggle and something I continue to try to reconcile because of the level of disparity that I see. So that's the operating room. We will usually, they have a few sets for cases. We literally open a set, and we have taught ourselves to do each surgery with the least amount of equipment, because each set we want to try to do maybe 4 or 5 cases out of it. So this is Dr. Tim Bilhars. He was with me on one of the trips. He's literally portioning out equipment, because that is our storage room in the middle. That is all there is for us to use. And for the rest of the other cases that are being done other than our cases, again, this is a district hospital that has a catchment of 500,000 people, and that's their storage room for the OR. You could see the operating room there, very small. There's a minor operating room, and then the one below that is the major operating room, and that's all they have. This is one of the incredible stories of, again, speaks to, being in a place where they're ill-equipped, they don't have enough things. So the twins we have there, so we showed up, and there was a woman actually in labor, and they said, this woman, this is her 5th baby, and she's been pushing for 3 hours, and nothing is happening. And her abdomen is really large. So we went and we were, sort of palpating, and I had two friends of mine. One of them is a radiologist here in the United States, and we were carrying basically an ultrasound that was like a hand-carried ultrasound. They didn't have ultrasound. So we put the ultrasound, and these babies are transverse. So this woman has been pushing for hours. She's having her fifth baby. She shouldn't be pushing for that long because the babies are laying sideways and they were never going to come out. So often what happens, she would have pushed, and eventually her uterus would rupture. She would bleed to death. Her babies would die, and so would she. So just with ultrasound technology, we were able to figure out that the babies were transverse, immediately stopped the pushing process, took her to the OR, and there's the twins. Morgan, who's right here, was in Malawi on one of the trips, and literally there was a woman there that was delivering. Nobody knew whether there was one or two, and so it was like, baby comes, oh, there's another one. Oh, there's another one. And so literally, she delivered triplets that nobody knew were even there. Because again, a simple ultrasound, something that if they had available to them, this is something that would have been prepared for. It was just happening, in the process. And luckily, those babies lived and did well. And then the last picture with the lady that's smiling, she actually showed up and she was laboring. And we discovered, because she had some bleeding, that she was actually laboring with a placenta previa. This is when the placenta is actually covering the cervix. And if she pushes through that, she would actually bleed to death. And so once we discovered that, she went for a C-section. And in fact, because she had already, the baby was engaged down by the cervix, she was bleeding so profusely, she ended up not just having a C-section, but also her uterus had to be removed. But at least it was a good outcome. She always wanted a boy. This was the boy she always wanted. And because she couldn't name her Annie, Tim got the pleasure of having a baby named after him. This is a young woman who got sent from a healthcare facility. They thought that she had polyhydramnios. She was pregnant. She had been getting care for 7 months. But her abdomen had gotten very large, and they thought she had too much fluid in her belly, or maybe she had many babies in there. So we were supposed to assess her for multiple gestation, and since we had a portable ultrasound, we put an ultrasound. It wasn't a baby. What we took out of her is that mass. So she was never pregnant, and yet had been getting prenatal care, and people in the village were treating her as a pregnant person. Again, all of this is just just lack of resources and equipment to be able to do that. So this is her with me post-op, and that was us removing the huge mass from the abdomen that she had. Divana was one of the, again, tragic stories. She has had 3 C-sections with not one live baby. And on her last C-section, the same story, where she showed up at the hospital, labored for hours and hours and hours, and by the time she made it to the OR, her uterus was ruptured, it was damaged. I remember her telling me the story that they looked at her and asked her, do you have any live babies? And she said, none. They said, unfortunately, your uterus is so damaged, this is not gonna happen for you. Her husband has left her. During the time that they had done her surgery, she also, there was some damage that was done to her bladder. And so when she came to see us, she was actually coming because she's constantly, leaking urine. It's an ongoing problem for her. She can't even afford, the sanitary napkins or Pampers just to be able to take care of herself. Mabel and I were just listening to a message of hers yesterday, where she's basically describing some of the things that she's going through, still suffering, from the process of delivery, and she doesn't even have a baby to show for it. I think this was a short video. I'm gonna have to run through these last parts really quickly because I think we're running out of time. My medical surgical trips that I make with teams from the United States. And the night before, I was actually headed back to the US after we had done over 42 surgeries in 2.5 weeks, where all the patients had recovered and had done well. I was called to the maternity ward because there was a baby who mom was pushing, and there was a shoulder dystocia. That's where the baby
actually cannot fit through the vaginal canal. And in the US, when a situation like that comes, you have an option to just push the baby back, run to the OR, open the mom, and deliver the baby by C-section with no problems, except that when I walked in, there was an acute realization that there was no way we could take a woman with a baby whose head is out and the shoulders are stuck. There was also a cord wrapped around the baby's neck like 3 times, and there was no way that I would put her in an ambulance, drive to the Salima District Hospital to an operating room that was likely going to not be available, and expect that this would turn out well. So it was a decision basically with the staff for us to just try to see if we could deliver her, because the baby, was already out. And we delivered her, and she was beautiful and perfect with no anomalies. And she never took a breath, and she never cried. And I remember taking her to the warmer and doing chest compressions and trying to provide oxygen, all the things we actually have available that aren't available at Salima District Hospital even. And I wanted so badly for her to breathe. And, the staff was in shock because they hadn't had that experience. It was the first time they were actually experiencing a neonatal death that happened on campus. And that's simply because we couldn't have just taken that woman just across that back door into the surgical center for an emergency C-section. And so they didn't know what to say. They didn't want to be the ones to go tell the mom. So I was basically given the responsibility to go to her while she was finishing getting repaired, and hoping that she was just going to be given her beautiful baby girl crying. And I had to sit next to her and let her know that she didn't make it. And her wailing, the wail that she gave out, is one that I'm never going to forget. And she mourned the 9 months of suffering that she had gone through carrying that pregnancy. I mean, this is a place where nutrition is hard to find. Staying healthy while you're pregnant is really difficult, and making it to term is a miracle. And she gets to term and she delivers, and this is the outcome. And I got to hear her essentially experience all the stages of grief you can think of. And I sat there and I remember holding her just while she screamed. I knew when I left that we have to make a change. We have to do better. And I remember even Nadia looking at me and saying, I've understood that there's disparity in healthcare delivery. I've understood that developing countries have low resources. I never understood it, that it was this level of desperation, where something this basic that seems to be like a basic human right is just not even available to these women. And for the first time, she's going somewhere where 500,000 people have one operating room to share. And so, I think that experience, other than also speaking to the importance of us having the operating room, is also being able to bring the US physicians that not only are they there to provide those emergency services, but one of my dreams is to really also see what this experience will be for United States physicians. And what it would be for them when they return on trips like this. My medical surgical trips that I make with teams from the United States. And the night.
There we go. So just real quick, I'll just run through this because I got the 10-minute warning. A well-functioning healthcare center is one that will provide in an enabling environment, which includes sufficient human and financial resources, essential drugs, and the necessary equipment. I'm just putting an example here of the operating rooms that I use here. Sorry. Yes. Sorry. Forgot. All right. Was everybody able to hear me? I'm pretty loud. Yeah. So, like I'm looking at the supply room that I was just showing you, that's my supply room outside of my operating room here in the United States, and that's an operating room that I use here. It allows us to be able to actually take care of people well because we have the things that we need and the tools that we need. Some of the things that we're working on in the process is really skills-based training where we're going to start going through the, processes of teaching what the right skills are. I have some examples here where people actually take I think Noelle is her name, she's like a dummy woman that gets to push, and she gets to have shoulder dystocias, and she can have C-sections and all sorts of things that kind of help people sort of learn how to do deliveries. So this is a group of my friends that are actually doing that program, and something that we're looking to be able to actually use and teach around the Salima area. And, ultrasound training, we actually bought a butterfly ultrasound. And one of the things that I do when I'm there is really work with the clinical officers, even just to simply identify that it's a head first coming, because sometimes even that is something that's, not clear to them. When we're doing the surgeries, that's me in the middle. We try to do as many surgeries as they can with the local staff so that we're training them, because at the end of the day, we're there for 2, 3, or 4 weeks, but they need to continue those skills after we're gone. And so training the local people needs to be the key. It's not about just coming and doing the rescue thing and then leaving. It's really about equipping them and giving them the capacity to do it on their own, because they can. They just need somebody to teach them. This is, we did a session. We had a neonatologist that came one year at the district hospital, because often when the babies are born, there's not a lot that's done. If they're not breathing, they just say the baby's not breathing. And, there's usually, they'll pat them on the back and then that's it. So he really went through the process of what do we do to help a baby breathe and how many babies they can actually revive. And so often when they notice that these blue babies that are coming out, that you could actually use all these different techniques, and all of a sudden the majority of them are breathing, it was really remarkable what that did for the staff, knowing what they can actually do with that. We've, really worked on improving access. We have an ambulance at the facility where if patients have emergencies that we can actually transport them. And I think equipping most of the healthcare centers with an ambulance is one of the things that help. We have a waiting shelter, actually, where for the women that live very far and they need to come camp out, then there's a place for them to stay where it's safe, and they can be, taken care of if they need to stay around while they're waiting for their delivery dates. All right. That was really quick at the end, but I had 10 minutes.